Assalamualaikum and a very good morning to everyone. Thank you for joining us in the sessions for breakfast at UMHealth. This is, I think, episode number 37. So today we have two sessions, one from orthopedic surgery and the other one is from preventive medicine. So I'm going to introduce my first speaker, Associate Professor Dr. Chew Chee Kit. He is currently the head of our spine unit or spine research unit, SRU. So he's going to give us a talk on management of osteoporotic vertebral fractures. So without further ado, I would like to invite him to give his talk.
Yeah, thank you, Prof. Faisal. So this is mainly focused on surgical management, but I will briefly run through what is the indication. So it's important to note that management of most acute osteoporotic vertebral fractures are still conservative. And previously randomized trials that compare between surgery and sham surgery noted that there's no difference between surgery versus sham surgery in patients with acute osteoporotic compression fracture. Then when is surgery needed? Because the focus of this today's talk is on surgery. So surgery may be needed in situation where patient has a condition called intravertebral cleft in association with the osteoporotic vertebral fracture. So what is this intravertebral cleft? It is a condition whereby the fracture fails to heal naturally, causing persistent symptoms, especially pain. And it's usually located beneath the end plate, superior end plate of the vertebra and anterior margin. It can be easily diagnosed using X-rays, CT or MRI, whereby it produces a air or a fluid sign or a mixed sign. I'll show this in more details later. So how should we approach it how do we diagnose it? Further, how do we treat it? So diagnosis is clinically by assessing the patient. The patient usually complains of very severe excruciating back pain. And this pain may not be located at the site of the fracture, but they may locate further down near the paravertebral muscle at the junction between the lumbar and the pelvis. And this especially is aggravated by changing position. When patient tries to get up from bed or turning in bed or getting up from sitting position. Why is it so? Is because of this cleft that is causing less stability to the spinal column. And when patient changes position, this causes some movement and aggravates severe muscle spasm in the patient, leading to severe pain. And the history can be subacute, chronic, and usually associated with fall with milder back pain initially months ago, and patients further develop more and more pain. So for people who, for us especially, we especially try to exclude neurological deficit in this group of patients because of the cleft that may be large and causing the instability or stenosis to the spinal column, leading to nerve or spinal cord compression and further neurological deficiency. Diagnosis by imaging, we can do a special X-ray. We call it dynamic stress radiographs. This is done by putting a bolster or a roll blanket behind the back gently, because patient may have some pain, so we gently put it, and also and taking a lateral view of this X-ray. and comparing it with an upright or a sitting X-ray. So if you have a sitting X-ray, you do one lateral sitting X-ray, you will notice that there is a fracture here. And when you do the dynamic X-ray by putting a bolster, this fracture will open up, showing you or revealing the cleft of this fracture. So of course, CT scan and MRI can also assist in the diagnosis. And both this CT and MRI can show fluid sign in this case. You can see a high signal on MRI T2 weighted scan will show fluid here, and X-ray CT scan will show fluid, a gap with fluid. Air sign is much easier detected on CT scan and X-rays by showing vacuum sign, and on MRI you will have low signal. So additionally, we'll look at the stir scan to look for vertebral edema indicating acute fractures. As you can see on the left, in this patient, there are 4 fractures, and to determine whether all these fractures are new or old, we look at the stir scan, T12, T11, and L2. There is no bone edema, indicating that these 2 fractures may be old fractures. And T12, L3 with a high signal indicating bone edema, showing that this would be maybe a new fracture. So how do we treat this patient once we have diagnosed them? Of course, if the cleft is small, less than 4 millimeter, as recommended by Professor Kwan in his book chapter, we can try conservative treatment. So with brace and painkillers. If just say the cleft is bigger than 4 millimeter, we can propose to the patient for a small local procedure with sedation. We can perform a percutaneous cement vertebroplasty. I'll show this later in the surgical technique. So this is for example, this is a patient who has a fracture, and you can see that patient has an intravertebral cleft. Confirmed also by CT scan and MRI. And we perform percutaneous cement vertebroplasty in this patient. If the cleft is very large and we are worried about the stability of the spinal column, we may additionally add stabilization with screws. We call it minimal invasive stabilization, as we do not need to do an open procedure. We can insert this screw via percutaneous method. If the patient has neurological deficit, then the indication to stabilize this fracture is now warranted, and we will perform a cement vertebroplasty with stabilization. So, for example, in this patient, 89 years old, you can see here, she has a cleft. Okay, this is the cleft. Confirmed on MRI is filled with fluid, high signal on T2. So we perform a cement vertebroplasty, and using small stab wounds, we perform a minimal invasive percutaneous stabilization with screws and rods. So if patient has an ankylosing spine, either a dish or ankylosing spondylitis, we may need to extend this fixation longer, as the stress to the fracture is higher in this patient with ankylosed spine. So for example, in this patient with again T12 cleft here, this patient's spine is ankylosed and all the stress is transmitted to the fracture. So all the movement, all these levels have very little movement. So all the movement will be located at the fracture site. So this is like a long bone instead of a spine, which is more mobile than long bone. So therefore the fixation, this MRI, and therefore the fixation may need to be extended longer. So long fixation with cement vertebroplasty. Of course, open surgery can be done in certain situations, but in most cases in our center, we will perform minimal invasive surgery. So how do we do percutaneous cement vertebroplasty? So the first step is to reduce the fracture by positioning. We put the patient prone, maximal extension to open up the cleft or the fracture. We use 2 trocar. We flush with saline, fill with cement, and then wait for the cement to harden. I'll show this technique. So this is how we insert the trocar. This is a view in the image intensifier in OT. So we insert the trocar using the image intensifier guide. This is the lateral view. So once we have inserted, then we will flush the saline in 1 trocar, and the saline will come out, fill up the the cleft, and then the water will be flushed out the other way. So we will wash the cleft, sort of. Okay, we can put contrast media to feel it, just to be sure that the feeling is not leaking elsewhere. Okay, then we wash the contrast media out again. And then now we begin to fill the cleft with cement. As you can see, the cement start to fall into the cleft slowly and start filling up the cleft. So it's very important to have 2 trocars rather than 1 trocar technique, because excessive cement can retrogradely flow out. So this prevents leakage of cement elsewhere. So this is the final filling, and the procedure, this procedure called percutaneous cement vertebroplasty. So in summary, it is important for us to diagnose this condition, osteoporotic vertebral fracture with intravertebral cleft, because the treatment strategy are different from acute fractures. There are many indications that may require surgery. And one of the common procedure that we do is percutaneous cement vertebroplasty. So in conclusion, we should not miss this cleft, as it may lead to persistent pain, poor mobility, and even neurological deficit. It can be diagnosed easily on radiograph using the dynamic stress view with confirmation with CT and MRI. So they are good treatment options, inclusive of surgical options, to treat this condition, to provide patient with good functional outcome. Thank you.
Thank you very much, Prof. Chikits, for that interesting talk on vertebral fractures. I think these are very common fractures, especially among the elderly, and I'm pretty sure among of our relatives, parents, and then our grandparents, especially, who is at risk of developing vertebral fractures. So, okay, so there are one questions in the Q&A box. What are the risk factors for developing intervertebral cleft? What are the risk factors to develop intervertebral cleft?
Yeah, it's a very good question. So I think if we look at the we can look in the point in the view of the patient factor is how porous is the bone. If the patient have severe osteoporosis, I would think that the risk is much higher. Second is whether patient receive early treatment for the acute fracture or not. Patient is braced early and advised not to bend forward and take care of the back posture. If not, with excessive mobility, this fracture will not heal and the cleft will form. Yeah. Also, if you look at the anatomical point of view, I would say that clefts are more common in the higher mobility area in the thoracolumbar junction, maybe lumbar, but less common in the mid-thoracic region. Similarly to fracture are more common in the thoracolumbar region because of the transition between a rigid thoracic cage to the more mobile lumbar segment. So if the fracture is higher up, maybe the risk of cleft is less. Yeah, then I think those may be the few risk factors that you have to look into. Yeah.
I think there's another questions in the webinar chat. Hi, Prof. What is the contraindication for this percutaneous cement vertebroplasty? So, which patient that you would do the cement vertebroplasty?
Okay, so one is if of course once we the first is the diagnosis. If we cannot rule out infection, then we may not want to inject cement into the vertebra because once we inject cement, it's not easy to remove it if there is infection. So therefore, we have to be very sure that this fracture is not caused by other pathology. It's just mainly osteoporosis. But if the diagnosis of osteoporosis is made, the few contraindication is if patient has neurological deficit, and the neurological deficit is due to a bone that is compressing the nerve retropulse into the canal, and this bone fragment does not reduce or in supine position. It does not fall back in front, and the stenosis persists on supine position. Then vertebroplasty may not be the option, as we may not be able to relieve the compression of the nerve compression. So therefore, we may need to opt for open surgery in this situation. Yeah.
Okay, thanks for that. And then there's another questions. How widely available is this technique in the country? So I suppose this is referring to the minimally invasive surgical technique, I think. Is it just limited to the academic centers from YK Chan? So is this questions for which technique is it? Is it the vertebroplasty or is it the minimally invasive surgical technique? Can we have a bit more specific questions? Yu Kun Chan?
Yeah, or if not, I can answer for both.
Yeah.
Yeah, if you don't mind. So if
Yep, can.
for
Yep.
cement vertebroplasty, the technique that we show uses very basic equipment. They just use two trocars, which is very widely available. These trocars are used for biopsies and is readily available. And the cement, we don't use any specialized vertebroplasty set, which costs higher. We just use cement and we mix it in our normal syringes. So therefore, the cost is low and is easily available. And most spine surgeon does this procedure, I would say. It's quite a
Very common.
basic procedure for spine subspecialty. Okay. For the screw fixation, minimal invasive screw minimal invasive stabilization using percutaneous screw. This is not this is already now, I would say, is quite widely accepted technique, surgical technique, but not all surgeons may adopt this technique. But I would say is getting more popular, especially for lumbar degen cases. Minimal invasive T-leaf is much more widely done nowadays, and they use the same technique of inserting screw as this fracture fixation.
Okay, thank you. And then another questions here. Prof, any timeline we can refer for surgical procedure from the onset of fractures? I mean, do you have any specific timeline whether you can perform the surgical procedures for this type of fractures?
Yeah, so it's not really timeline. So usually we look at two factors like how big is the cleft. So if on dynamic X-ray, the cleft is less than 4 millimeter, we will always advise the patient to try to try to take painkillers and wear a brace, and we will adopt a conservative management first. If that fails to relieve the symptom, then only we may consider surgery. If the cleft is more than 4 millimeter, then we offer two options for the patient. If whether they want to do the cement vertebroplasty to reduce the pain, or they can still opt for conservative treatment with brace and painkillers. So the timeline, there's no specific timeline, but if you were to say, if patient is developing neurology, I would strongly encourage surgery because this will prevent permanent deficit in the patient. Yeah.
Okay. Maybe there's no more questions in the Q&A. So I think my last questions, I think really just to, so how do you advise the patient? Because you know these are quite common in the elderly populations. I think in terms of preventive measures, how do you advise the patient who just had a vertebral fractures so that they don't have further fractures to the adjacent vertebra?
Yeah, thank you for the question. This is very important because we don't only advise patient with fracture, but all spine patient. So in our unit or our group, we strongly advise patient good back posture. So we have a video on this. I think you can get it from our clinic, the QR code. And the posture is very important. It's not what you do, it's how you do it, how you do things. Like you want to pick up objects from the ground, you want to get up from bed, get up from sitting position. The posture is very important. So to summarize, a straight spine all the time is very important unless no choice. Okay, the second thing that we advocate is strengthening the back core muscles by doing back core exercise. So there are many exercises that all of us will do, but some exercises doesn't focus much on the back core muscles. Example of exercises that focus on back core muscles are swimming, but running may not focus that much. So therefore, you may need to supplement with specific back core exercises. So we have a few exercises that we propose in the video as well, like back extension exercises, or they call it Superman exercises, plank, and others. So the two key concepts of preventing any fractures or any back-related problem, one is back care or good back posture. Second is back strengthening your back core muscles, which is back exercise. Yeah.
I think just last questions before we end from the Q&A box. Is if it's all fracture, do we still proceed with surgery or just conservative for all fractures? How do you treat all fractures?
Yes, thank you for the question. So like in one of the case that I showed just now, there are 4 level fractures and two are new, one with a large cleft and 2 are old. So for old fractures, we don't usually need to treat it because they already have united. So we can leave it alone. So no treatment needed. Yeah.
I think one last more. I think Prof. Victor Ho, what type of back exercise do you recommend? I think you just answered that about the video, I think. Yeah. Or maybe you can share
actually, we proposed a few, but for me, I think any exercise that focuses on back muscles, we can do it. So for younger patients, they sometimes ask us whether can they do gym related back exercises. So I say it's okay as long as they do the right technique without hurting the back. So they need to start very, very carefully and very gradually. So they can do all these exercises and improve the back core. So any exercises that focus on back core muscles can be done. Yeah.
Okay, I think our session has ends now. I think thank you very much, Prof. Chikit, and then thank you for the participants with the questions. To we proceed to the next sessions from the social and preventive medicine. Thank you.
Yeah. Thank you, Professor.